Thank you for joining us this Thursday evening for our webinar, a conversation on voluntarily stopping eating and drinking. My name is Ayanna Woods. I'm the Executive Director of End of Life Choices New York. End of Life Choices New York seeks to expand choice at the end of life, respecting every individual's wishes and striving for the best possible quality of life and a peaceful death. For more than 2 decades, End of Life Choices New York has worked to achieve better care and more choices for the dying through advocacy and education, free counseling for patients and their families. And we are committed to fighting for the right of terminally ill New Yorkers to control the circumstances and timing of their deaths. Our goal is to promote quality healthcare choices, health equity, human rights, autonomy, justice, and the relief of suffering. Thank you for joining us tonight. I believe we have nearly over 200 people registered for this event. And I hope you continue to attend our events by following us on social media, going to our website, and signing up for our newsletter. We offer educational programs like tonight's event, but also professional development workshops. We have a host of materials, videos, handouts, and other resources. And we are also available to answer your questions. This is our 6th annual Barbara Schwartz Lecture. Barbara Schwartz served with distinction on the End of Life Choices New York board from nearly its inception until her death in 2014. She was a longtime advocate for human rights and passionate about expanding options at the end of life. This lecture series highlights important end-of-life topics and features the leading experts in the field, and we are so delighted to have an amazing group of panelists for tonight's presentation. I'll pass it over to our board president, Christina Coons, who will be moderating this event.
Thank you so much, Ayanna. Thank you also to the panel we have here tonight. It is a very exciting night. I also want to welcome our Case Management Society Association Coalition. We are representing area chapters from New York City, Long Island, the Capital Region in Albany, New Jersey, Mid-Atlantic, which covers Delaware and Maryland, and then our lovely Hudson Valley, New York, which you can see from the screen behind me is the Mid-Hudson Bridge taken along the walkway. So we're excited to have everybody here. And I just want to point out for those professionals for CEUs, case management CEUs, CCM, we will post our code at the end in the chat. And social work CEUs, we will contact you after the end of the program. So I am going to kick this off right away with an introduction to our first speaker, Judy Schwartz, who has her doctorate in RN. Judy is a clinical director of End of Life Choices New York and was the East Coast clinical coordinator for Compassion and Choices. She has counseled many hundreds of patients suffering from incurable and progressive or terminal illnesses and families about the end of life options. She publishes regularly in nursing and palliative care journals. For years, her work has focused on voluntarily stopping eating and drinking as an option to achieve a peaceful, patient-controlled death. More recently, she began responding to requests for assistance from patients diagnosed with an early stage of dementia. With colleagues in other disciplines, she developed the End of Life Choices New York Dementia Directive that has been completed by hundreds of individuals, and she will be touching on that this evening. Welcome, Judy.
Thank you. Are we going to move the slides on? I want you to know why we wrote this book. We come from distinct backgrounds, from nursing, medicine, philosophy, and law, but we all had struggled and thought about VSED, which is our way of talking about voluntarily stopping eating and drinking, because each of us had patients or their families who asked us to think about this and to advise them. We worked together on this book to help others learn about what we think is often a misunderstood and underutilized end-of-life option. Next slide, please. So why do folks call us? Why do we hear from people seeking end-of-life options? This is what I'm going to talk about. I'm also going to talk about why VSED is so featured in all of these end-of-life discussions. What needs to be in place for a successful VSED outcome, and how do we define success? Pros and then I'll discuss the pros and cons of and unique challenges of VSED and what happens if decisional capacity is lost. Next slide, please. So why do folks call us for guidance? The folks that do call us tend to be in one of two diagnostic categories. The first group are those who've been diagnosed with a terminal illness, which means that some often physician has made a guesstimate that they'll likely die of their disease within the next 6 months, or they're suffering from an incurable and progressive disease. Both of these people are suffering, both of these groups of individuals are suffering in ways that they find distressing. They want information about options and choices. Sometimes it's just about symptom management. Sometimes it's help with advanced directives, but sometimes they want information about controlling the circumstances and timing of death. Next slide, please. So I'm not going to talk much about the New York State healthcare law because mercifully we have FAD to help us with that. But I am going to talk about how folks within New York State sometimes are stymied by the law. Many are shocked, I tell you, shocked to learn that there's no access to physician-assisted dying in New York State. Many of the folks that call me know from experience that not all pain and suffering can be managed, even with excellent palliative or hospice care. And even when their loved ones want to help, healthcare agents, they have no clue how to do that. And it's important to know that appointing a healthcare agent who knows about your wishes is extremely important, but that may not be enough sometimes. And those are the issues we're going to talk about today. And I can tell you for sure that few in New York State know that VSED is the only legal option for patient-controlled hastened death in this state. Next slide, please. So these are the 4 preconditions, the things that must be in place for VSED to proceed. The first thing is a very well-informed and determined patient who is suffering intolerably in ways that they find just unbearable and who has no good alternatives as a means to control the timing of their death. The second thing they need is psychosocial support from family or friends who understand the reason why they've made this decision. They understand also what to expect going forward, what the process will be like, and how they can help. They need to be committed to accompanying the patient throughout the journey. And they also need to provide ongoing care to that patient. Next slide, please. The third thing that must be in place is access to palliative or hospice clinical oversight. This is both for managing ongoing symptoms, but it's also to help guide discussions about how caregivers are to respond in the event or the likely event that the patient will lose capacity as death nears. Ideally, the patient will tell the caregivers and the family members how they want any kind of request that's at odds with their wishes to be handled. A patient with VSED, the last thing they need is patience, because the process unfolds over time and there's often not certainty about the length of that process, particularly if the patient is finding it challenging to forego all fluids. Next slide, please. So this is my definition of a successful VSED outcome, and that is that it is a death that is relatively peaceful. It is accompanied by adequate symptom management, and it occurs within a predictable period of time. We know that the average length of time for a terminally ill person to fast with nothing by mouth is about 10 days. However, any kinds of fluids drunk, taken, prolongs the process. And it's very important to understand that to achieve a VSED death, which is from dehydration, the patient must be able to strictly limit fluid intake, and that can be challenging. Next slide, please. So here are some of the pros and cons and unique challenges of VSED. First, the good stuff. It's available to any decisionally capable adult who experiences unacceptable suffering, and they get to decide they get to define what unacceptable suffering is. They don't have to be terminally ill. As I said, that 6-month prognosis. And many people find that it's similar to a, quote, natural dying process, which almost always involves loss of appetite and disinterest in fluid as death nears. And I can tell you for sure that folks have been dying this way for generations. They may not have called it voluntarily stopping eating and drinking, but it happened. And the other thing that's comforting to many people is they don't need anybody's permission or approval. It's legal for patients and caregivers to provide support and for patients to make this choice. And it can be managed without medical support, although we certainly never recommend that. And the family can remain present, and they're part of being present during the process. Next slide, please. So some of the challenges, well, it takes time, days to weeks, and that length of time can be uncertain, and that can be extremely frustrating for both patients and family members. Foregoing all fluids can be extremely challenging. We say challenging when it's really hard. Although good oral care can relieve the distress of a dry mouth. It requires a good deal of upstream planning. For example, you have to be able to hire aides who will accept this plan of care, because as people end up being bedridden, and they will need 24/7 care that often a family member can't provide. It's also not a good option for those without family or friends to provide emotional support and care, and that leaves out, sadly, a fair number of people. And in the absence of a terminal diagnosis, securing palliative symptom management can be difficult. Next slide, please. And these are the unique challenges that are incumbent in VSED. The person intending to VSED must be very, very determined to control the circumstances and timing of death. And they must be decisionally capable when they make the decision and the process begins. And by decisionally capable, I mean that they're able to make an informed choice based on the information that they're given. They understand the consequences and they remember the choice that they've made. That's key. No doubt, they will lose capacity as the process unfolds, and they may forget their decision to stop eating and drinking and request fluids. This can be extremely stressful for caregivers, and it must be anticipated and a plan put in place so everybody knows how to respond. Completing a written directive about feeding wishes while still decisionally capable is helpful. It's a guide for family and providers, and we'll talk more about that later. Next slide, please.
Judy, 1 minute.
Okay, so I'm almost there. This is just one very quick look at advanced directives. You know that End of Life Choices New York has a dementia directive. We call it an advanced directive to stop eating and drinking. It is completed while the patient is decisionally capable, and they get to decide whether they're going to limit or completely withhold future provision of hand feeding when capacity is lost and dementia is advanced. We also recommend that people who are choosing to VSED also complete a written directive indicating what their wishes are. And it's recommended for all of those who have diseases where capacity will likely be lost in the future, for example, dementia or Parkinson's disease. Last slide. Thank you for your attention. I'm looking forward to being able to have these meetings in person soon. Remember that you can call our patient support number and leave a message on any time at all, and I will call you back as soon as I can. That number is 212-252-2015. Thank you. I'll look forward to your questions.
Wonderful. Thank you so much, Judy. And we will have a Q&A panel at the end, towards the end of our presentation. I do want to point out that not only professionals can call this phone number, but you may share this with potential patients as well. Okay, on to our next speaker. We have the pleasure, everyone here is a pleasure to have on board. Tim E. Quill joins us. He is a medical doctor and a professor of medicine, psychiatry, medical humanities, and nursing at the University of Rochester School of Medicine, where he was the founding director of their palliative care division. He was a board member and past president of the American Academy of Hospice and Palliative Medicine. He was the lead physician plaintiff in a U.S. Supreme Court case, Quill versus Vacco, testing the legal permissibility of physician-assisted death. Quill is a practicing palliative care physician today, an author-editor of 7 previous books, multiple peer-reviewed articles in major medical journals, and a regular lecturer and commentator on medical decision-making, physician-patient relationships, palliative care, and end-of-life issues. Please welcome Tim. Thank you.
Thank you so much. It's a pleasure to be here with you today. I'm just going to dive right in because our time is limited, and start out by saying I don't have any financial conflicts of interest on this topic, although clearly I am an advocate and I have a point of view about this. Next slide, please. So there are 3 aspects of the clinical question about what options do I have. In the future might be one, if my dying becomes unacceptably difficult for me, or if I lose capacity, which is often a deal breaker for many patients and families, and might be a deal breaker for me personally. Now that's in the future, worried about the hypothetical. There's also the more pressing now, because my dying is currently unacceptable. So those are the circumstances when this question may come up. Next slide. So again, reassurance about the future. Who's going to be working with me? Do I have a partner? If I am the clinician working with this patient, I might ask what they're most afraid of, what death might look like for them, what options do I have if capacity is lost? And if I can work with somebody who can say, I have a way of helping you face these kinds of things. I'm going to face my illness and what I can do for the last part of my life with a lot more courage and sense of well-being than if I don't have such a partner. So those who know they have a good partner really are free to spend their time and energy on other matters. Next slide. But they're also, if you've made such a commitment, we have to be ready to say, respond to, I'm ready to die now, which some people, this is a subgroup of the people who are worried about this. Again, palliative care and hospice care work most of the time, but some people reach a point where they're ready. And when that happens, that's the beginning of a discussion. And we start asking, why now? What makes your suffering so unacceptable right now? What treatments have been tried so far? And there's a differential diagnosis to this request. It might be uncontrolled symptoms. It might be that the family's gotten tired of caring for them. They may have spiritual questions about why a caring God might have allowed this to have happened. They might have become clinically depressed or anxious. And they may just be dreading the future, or they might actually be confused. And also, they may just have reached a point where their suffering is uncontrolled and intolerable to them, and that could be a mix of physical and psychosocial suffering. Next slide. So if and when capacity is lost, this all gets a lot more complex. If you previously stated that you'd rather be dead than incapacitated, then that comment might be very helpful to those caring for you. All professional and family caregivers need to have heard these prior statements, because you have to try to imagine what the patient would want if they can no longer speak for themselves. If capacity is now clearly lost, then you have the question of, does this past self who didn't want to live this way need to be listened to, or should it be the current self who might be okay with the way things are? So this can get pretty complex at times. There may be immediate evidence that current suffering may be very strong, but it may not be that strong if capacity is lost, in which case the caregivers have a dilemma. And clearly you want to make sure a purely palliative approach is in place, because that would be the standard of care. So how far can we go to accelerate the dying process under these circumstances? Next slide. So these are the last resort options, the options for maybe responding if somebody has said they're ready now. So again, if they're having a lot of anxiety or confusion or distress, then they could be sedated to help relieve that distress, or they can get more aggressive pain management or shortness of breath management if that's the driving force. If a person's on life support, they can then stop those life supports. And some of the life supports are big ones like ventilators, breathing machines, or dialysis machines, but it could also be simpler ones like steroids for brain cancer, or different kinds of medication or fluids. And then and there's wide agreement that those treatments can be stopped if a person chooses to do that. In the yellow area, there's stopping eating and drinking, what we're talking about tonight, as an option. And then there's also palliative sedation, a way of helping people escape distress by being sedated by clinicians. And it might even be sedated to unconsciousness. And then in the red area are the areas where there's most controversy: physician aid in dying, which again is illegal in many parts of the country, legal in some states, and then voluntary euthanasia, which is not at all legally available in the US, but might be legally available in the Netherlands and other places in the world. Next slide. So what about voluntarily stopping eating and drinking? This requires a clear, lasting patient decision. Patient must be cognitively intact enough to not eat and drink, which is actually gets pretty hard if you're thirsty and hungry. So it requires considerable patient resolve. The process, if you're able to really stop eating and drinking 100%, usually takes somewhere between 1 to 2 weeks. Could be a little shorter if you were particularly sick going into it, and could be longer if you were particularly robust going into it. It theoretically doesn't require a clinician or a physician involvement, but it sure helps to have them there, as symptom management may become a difficulty as the process unfolds. Next slide. So some real pluses of VSED. VSED is the short for voluntary stopping eating and drinking. It's a process with a beginning, a middle, and an end. So there's a built-in check against impulsivity. You don't do it just on a bad day. So patients can change their mind after they've started it. You can work on life closure if desired for this period of time. And it permits time for meaningful goodbyes, much like occurs on hospice in the later stages. It doesn't necessarily require direct medical intervention, but clinician presence or participation is generally indirect, and their participation really is important in terms of evaluation, preparation, and execution of the plan, and being ready to respond if clinical difficulties arise in the process. Next slide. So there are some negatives of VSED. There's not necessarily a requirement of a serious illness. Someone without any illness could potentially die by stopping eating and drinking. So the prognostic criteria are not clearly agreed upon, and it could be available to those with psychiatric illness if they weren't carefully evaluated up front. It does not necessarily require clinician involvement, but again, evaluation is critical. Why do you want to do this now as opposed to last week or 3 weeks from now? And there may be a mix of medical and psychiatric issues and motivators that underlie this decision. Some clinicians might refuse to participate also, and they might view it as assisting in suicide, which might go against their moral standards. And other caregivers, family and professional caregivers, might also undermine the process by trying to encourage somebody to eat or drink who's trying to carry this out. Next slide. There are also potential psychiatric issues. Again, does the patient have capacity? Are they able to make a stable choice about this? Do they use reason and logic to make that choice? And capacity is not an all or nothing thing. So again, this is understanding this particular decision. So you don't have to necessarily be able to balance the checkbook, but you really have to be able to make sure you understand the implications of this whole decision. And if there is uncertainty about capacity, a psychiatric consultation is a good idea. If you can find a psychiatrist who'd be willing to see such a patient, perhaps in their own home. Delirium and associated lack of capacity often occurs late in the process. So that should be anticipated and discussed in advance. And again, if a confused patient decides they want to eat or drink, we ought to have discussions up front about how they want us to approach that. So we tend to follow the individual patient's views and values in this circumstance. Next slide.
Tim, 1 minute.
Okay, so considering VSED, who might be the best candidates for this? Very disciplined, control-oriented people, ready for death that is coming too slowly, supportive family who agree with the decision, and then who should be told about this option in advance? All seriously ill patients, so they know it's possible. That I would put a question mark on that, because a lot of people might not want to know about this, might be frightened by it. Should we only tell those who are asked about assisted dying? Should we only tell those who are dying badly despite good care? Next slide. So the clinical mandates, I want to ensure that symptom management is optimal, explore all available last resort options, invite a second opinion if there's uncertainty, ensure fully informed consent, and engage patient and family participation as the patient allows. And then get prepared. Who's going to be committed to doing this? Think about a start date, time for saying goodbye, and then the logistics of hospice, where to allow this to occur, who's going to be the supports, and what are the backup plans. So I'm going to stop with that. And I have a couple of cases we can go to later if we want to go to, but I'll stop my conversation right now.
Thank you so much, Tim. We are going to move on to our next panelist. We have Paul T. Menzel, Professor Paul T. Menzel, Professor of Philosophy Emeritus, Pacific Lutheran University. He has published widely on moral questions in health economics and health policy, including Strong Medicine, The Ethical Rationing of Healthcare, and as co-editor, Prevention versus Treatment, What's the Right Balance? Most importantly, he has written on end-of-life issues, including advanced directives for dementia and voluntarily stopping eating and drinking. He has been a visiting scholar at Kennedy Institute of Ethics, Rockefeller Center, Bellagio, Brocker Foundation, Chinese University of Hong Kong, and Monash University. Please welcome Paul. Thank you.
Thank you, Christina. I'm going to focus on the relationship between VSED and suicide. This is more than just a philosophical question, though it is certainly a philosophical question. I will note in 4 successive slides here that VSED is suicide in a clear sense. It's not suicide in another clear sense. It may not matter which it is ethically, but it perhaps does really matter ethically when we come to assisting it. Next slide. Should VSED be seen as and labeled as suicide? Here's the case that it is. The definition of suicide is intentionally aiming at one's own death and directly causing it. Typical VSED definitely, clearly includes both elements, especially clearly because you cannot survive without food. So with certainty, VSED is going to cause death if you follow through with it. This is different than increasing morphine dosages to what is needed to maintain comfort, which is often defended by the principle known as double effect, where the intended effect is comfort. The foreknown effect, to be sure, is ultimately death, but foreknown effects are not do not lay blame on the agent who causes them. Only intended effects do by this principle of double effect. That principle does permit increasing morphine dosage, which is known ultimately to cause death. It's also different, he says, different than refusing treatment that's life-saving, because one might live anyhow. There are cases, many cases, where people refuse what they think are life-saving treatments. They expect to die, but they don't either die soon or they don't die for quite a long while. And VSED is very different on that score. Next slide. On the other hand, VSED isn't suicide. Suicide as a label is associated with despair, irrational pessimism about the future, secrecy, and often violent means. VSED is none of these. Suicide is typically seen, furthermore, as tragic, or at best unfortunate. But VSED isn't, unless one assumes already that it is tragic, which would be, as philosophers say, begging the question and assuming that it's wrong and tragic just because it causes death. We might think of the labeling issue as parallel, for VSED, as parallel with the labeling issue for medical aid in dying, where laws that legalize in the states where it is legal in the US, or in Canada where it's legal, laws that legalize medical aid in dying explicitly say that a person who assists in it is not assisting in a suicide because medical aid in dying is not suicide. The person who uses it is not committing suicide. Next slide. Even if VSED were suicide, would it be wrong? If in the person's circumstances, death is not bad, why would hastening it intentionally and with certainty ensuring it and being its primary and direct cause oneself be wrong if what is caused isn't wrong? That is, death in the circumstances is not bad. Excuse me, what is caused is not bad. If anything, bringing about death in this circumstance and in this way by VSED would be better than waiting for it to come. So even if it were suicide, it isn't wrong. On the other hand, next slide, it's often going to be seen as suicide, and people who assist it may wonder whether, well, it's maybe technically suicide, but it isn't in the way we use our terms in society about suicide. It doesn't really deserve the term suicide. But what about assisting it? Does it put me on the edge as a caregiver, on the edge of assisting in a potential suicide? Might assisting it be wrong, even though it is not wrong for the patient to do it? There's a parallel here in the law. Suicide is generally in the law, although we're talking about moral wrongs here, not legal wrongs, but if we switch to legal wrongs, suicide is not wrong legally. That is, we don't punish the person who does it. They're not here if they do it successfully, and if they do it unsuccessfully, we treat them, we don't punish them. But on the other hand, somebody who assists a suicide is open to considerable criminal penalties. Could that be the case with VSED also? I would argue definitely not. Because VSED is better than just not wrong for the person doing it. It is their moral and their legal right. Now, let's leave the legal right out of it for the moment, since I'm talking about the moral issue here. VSED people have a moral right not to have food forced on them. The only way you can force a person not to do VSED is ultimately by force feeding them with a feeding tube if they're insistent on not eating. But that, of course, is medical treatment, and they have the right to refuse medical treatment, even when it's life-saving. So they have the right to refuse the feeding tube. Conclusion, they have a right to VSED, very clearly, and this is a moral right, not just a legal right. If clinicians do not support patients in exercising their moral right, they are failing to support patients precisely in doing what patients are properly doing. And not to support them with palliative care to assist them in achieving a good death by VSED is in fact a violation, I would argue, of the physician's argument, the physician's loyalty to the patient. So, in conclusion, although VSED is, in a sense, suicide, and in another, I think, more important sense, not suicide. Even if it were suicide, it would not be ethically wrong. And furthermore, assisting it is not a wrong. Thank you.
Thank you, Paul. Okay, we are introducing our last panelist speaker. We are bringing on Professor Thaddeus Mason Pope, JD and PhD. He is director of the Health Law Institute and professor of law at Mitchell Hamline School of Law in St. Paul, Minnesota. He has over 200 publications in leading medical journals, law reviews, bar journals, nursing journals, bioethics journals, and book chapters. He co-authors the 1,500-page The Right to Die, The Law of End-of-Life Decision-Making and runs the popular medical futility blog. Pope has co-authored clinical practice guidelines for medical aid in dying and major policy statements on critical care ethics for professional medical societies. Apart from his scholarship, Pope has served as a legal consultant and expert witness in court cases involving end-of-life treatment. Please welcome Thaddeus.
Thank you. All right, so we're going to move on to the legal issues. Let me take you back almost exactly 5 years to October 2016. At that time, the four of us, Tim, Judy, Paul, and myself, were in Seattle. And we are at Seattle University having a multi-day conference with several hundred participants on VSED. And I was asked back then, 5 years ago, to talk about the legal status of VSED. And it was kind of hard because there wasn't actually a lot to go on, right? I had to admit there really aren't any statutes. There's very little case law. And the reason for that is because for a long time, VSED has been the Cinderella of end-of-life options, sort of neglected in comparison to her stepsisters like medical aid in dying. So fast forward 5 years to now, when we have this book come out, things are actually, from a legal perspective, a bit clearer. So here's my roadmap in 5 parts. First, I want to tell you about on-point precedent from the courts, the right to refuse medical treatment, the right to refuse any unwanted intervention, the fact that VSED is accepted by the medical profession, and the fact that there have been no sanctions imposed on anybody for doing VSED. So in terms of on-point precedent, there are multiple appellate court decisions saying that patients have a right to VSED and that clinicians may honor that decision, right? And those court decisions come from a number of different states. In New York specifically, there are several court decisions, one involving this former college president who was in a Syracuse nursing home, announced his plan to VSED. The nursing home was unsure whether they were allowed to honor that choice, so they go to court to clarify that, and the court said, yeah, absolutely, you're allowed to honor and respect that patient's choice. Other New York courts have said the same thing. And we have pretty much the same exact clarity from the courts from a number of other common law countries as well, like Australia and Canada. Now, that's really just a bonus. There's an ice cream store that used to be near my house called Izzy's. And when you ordered a scoop of ice cream of one flavor, you could get for free a second smaller scoop that they put on top of your main scoop, and that was called the Izzy. The point is, the fact that we have this on-point precedent is really just an Izzy, because VSED is clearly already legal, because we all have a right to refuse medical treatment, right? So we don't need direct, explicit authority saying that. It's already legal under existing rules. So we have this right to refuse treatment. That's been well established in New York for more than 100 years, right? Going back to the Schlellendorf case. And more recently been codified in things like the Patient Bill of Rights. Now, when we think of a right to refuse treatment in the end-of-life healthcare context, we often think of things like mechanical ventilation, dialysis, CPR, antibiotics, and feeding tubes. But it includes other things as well, like ICD devices, and it also includes VSED. Why? Because it's, as you heard, it's not do it yourself. It's part of a broader treatment plan, right? It's supervised by licensed healthcare professionals. And it's recognized as healthcare by the medical profession. We have a lot more position statements from healthcare societies. We have more clinical practice guidelines. In fact, some people call it PAVSED instead of VSED, palliated and assisted voluntarily stopping eating and drinking, to further emphasize and highlight the role of clinicians. So just to recap this point, right, we have this right to refuse treatment. It includes VSED, falls within the scope of that right. Why? Because oral nutrition and hydration, when delivered by healthcare professionals, is treatment. Now, some people say that oral nutrition and hydration is not treatment, rather it is basic care. So they say, well, you definitely have a right to refuse this. You have a right to refuse a feeding tube. But when you ask the different question, do you have the right to refuse this, a glass of water, or the right to refuse this, hand feeding or spoon feeding? Well, the answer is definitely yes, you do. Why? Because you have the right to refuse any intervention. So it doesn't really matter whether or not food and fluid by mouth is or is not medical treatment. You have the right to refuse any intervention, medical or not. Any unwanted contact, you have the right to refuse, right? And as Paul said, right, to override that choice, to override that refusal and force feed the patient would be a battery. As our former Chief Justice Rehnquist observed, one's bodily integrity is violated just as much by sticking a spoon in your mouth as by sticking a needle in your arm. So another point is professional societies recognize the validity of VSED. That matters because the law delegates and defers a great deal to healthcare professionals, right? So when the medical profession says that something's appropriate, the law often follows. And the medical and healthcare societies do say that VSED is appropriate. The American Nurses Association, the American Medical Women's Association, AMDA, the Society for Post-Acute and Long-Term Care Medicine, ESPEN, and a number of palliative societies in Europe. We also have a lot more clinical guidance from state medical societies, from published in places like JAMA and the Journal of the American Geriatric Society. And finally, it's worth noting that no sanctions have been imposed on anybody participating in a VSED. In our book, we have a number of appendices, and one of them, we collect dozens and dozens and dozens of personal narratives. So these are people or their families or their clinicians writing about somebody who used VSED. So all these cases, right, where VSED was used and VSED was reported, but despite the fact that VSED has a prevalence and has had a prevalence for some time, there have been no cases of liability and no cases of a nurse or a doctor or anybody else being investigated or disciplined by a healthcare licensing board. So I'll stop there. Thank you.
Excellent. Thank you, Thaddeus. Okay, I am going to ask now that our panelists, we are going to discuss the advanced VSED, advanced directive, to SED. So I'm opening it to the panelists.
Hello, I'm going to start again because Judy here in New York, we have this thing, the End of Life Choices Dementia Directive that I mentioned very, very briefly. This was designed for people who have been diagnosed with an early stage of a dementing disease, either Alzheimer's or perhaps Parkinson's, and they want to have the opportunity to limit future hand feeding by somebody else when they lose the ability to feed themselves due to advanced dementia and they've lost capacity at the same time. So our dementia directive answers the three important questions that are raised in Appendix A. I refer you to Appendix A in our book, which talks about what ought to be included in a written advance directive to stop eating and drinking. And the three most important things, just to keep it short and sweet, is Who's supposed to implement the choice that you've made in your written statement? And we would certainly suggest that that would be a healthcare agent, a proxy who you have appointed and told about your wishes so that they understand how you want your fluids or hand feeding limited or withheld. So that's number one. Number two, when should this limitation begin? Under what clinical circumstances should that happen? And the final thing is, what do you want withheld? Do you want everything withheld? Do you only want some things withheld? Do you want comfort feeding only? And you get to decide that, and you decide it ahead of time and you write it down. So I'm going to stop there and let other people jump in.
I'm just going to say that there are two circumstances where this is irrelevant and I must say difficult. One is a person who thinks they would want this, but they want it to be done after they lose capacity. And I think that's a very legitimate thing, because often losing capacity is the deal breaker. I think that would be a deal breaker for me. But what's challenging about this is, what about, you've lost capacity and you are really enjoying feeding and eating and drinking. So I think that becomes very difficult. So I do think the fallback position in that circumstance is going to be minimal comfort feeding only. So you give the basics of what a person needs just for basic comfort, and that would be, and no more, no less. So if they don't want anything, that's great. If they want a little bit, that's great. If they want a little more than a little bit, that's great. But you try to err on the little side, because that's what the person has said very clearly they want. Withholding, when people really are showing an interest in this, I think is just challenging logistically and morally for the caregivers, even if you know that the former self will need it. And Paul will talk to us about the then self, now self stuff, which I think is very problematic in this zone.
Agreed.
I agree with Tim that there certainly are real greater challenges in advanced directives for stopping eating and drinking. And when we get to actually implementing them, that is stopping eating and drinking by one's previous advanced directive, than there are with VSED by a person who has decision-making capacity at the time. I don't think these challenges are full barriers to doing stopping and eating and drinking by advanced directive, however, but as Judy mentioned, there are definitely some ingredients that are important. The first ethical, or what I will call ethical challenge number one, happens if a patient swallows food that's offered. Does the mere fact that she swallows it, she no longer has capacity. That's why the advanced directive applies. It applies only when she's lost capacity. But if, having lost capacity, she swallows food willingly that's offered to her, hasn't she changed her mind about her advanced directive for stopping eating and drinking? Now, one thing I would say, no. She has not changed her mind about her directive. She may have changed her mind compared to what she thought in advance. She thought she may not want to eat. She may not even want to swallow when she wrote the directive. But actually, anybody who's informed about behavior that they might evidence later when their advanced directive for stopping eating and drinking would be applied would need to know that sometimes you'll want to swallow food. You'll willingly swallow food. I answer nonetheless no, because she hasn't enough of a mind left to change her mind about her directive. She's no longer competent to change her mind about it, to change her directive. She doesn't understand it. She doesn't even know she has one. Moreover, more fundamentally, her advanced directive is still her directive. She is not a numerically different person. We'll get to this more with the then self, now self problem. Persons, philosophically speaking now, are beings who have temporal extension. if I can't imagine anything about my future and I don't remember anything about my past, if I am really strictly just living in an eternal present, am I a person? I can't have desires about anything in the future. I can't make plans. In all these dimensions that we regard as so important to respecting ourselves as persons depend on temporal extension. And so she is not a different person. She's still the same person as the person who wrote her advance directive. She just isn't of the same mental state right now. But it's not a different enough mental state. She's not competent enough to have actually changed her mind about her directive. Next slide. The perhaps more well-known challenge is the then self, now self problem mentioned by Tim and Judy. The advance directive of a person, let us suppose, is now in conflict with the current self, the now self, who wants to eat. The then self is the self who wrote the advance directive. The now self doesn't care about autonomy, doesn't remember she has an advance directive, and may in fact be quite comfortable in the current situation. But I would argue she is still the person who wrote the directive, and that person had a view about her life. She is still the person who had a view about her life when she was capable of having a view about her life. Furthermore, that life is now still her life. It's not nobody else's life, that's clear, and it's not no one's life. There still is a life here, and whose life is it? It's her life. It's the life of the same person who wrote the directive. One commentator decades ago put this by saying, we must not treat a previously competent person who wrote a directive as if she had never been competent, because right now she is still a person who was once competent and wrote the directive. She's that still now. And so to carry out her advance directive, even though she may willingly accept food, and may be even somewhat uncomfortable when food is withheld, is not violating standards of treatment for her, given the larger picture here. Furthermore, in her advance directive, as Judy had mentioned, something ought to be said about the palliative measures that would be taken. How much sedation, how much anti-desire to eat drugs should be given. Those can be specified in the advance directive. Those are just treatments that people can specify in their advance directive. And so the discomfort she might be feeling in food and drink being withheld can be ameliorated. Not completely. It is more difficult, as Tim Quill has noted, in actual clinical situations, but it can still be addressed directly in an advance directive. Furthermore, the then self, now self problem is not unique to advance directives for stopping eating and drinking. It affects and poses a challenge to all advance directives, where a person said in advance they didn't want certain life-saving treatment. That's clearly within the understood legitimate scope of an advance directive. And yet, people who in advance directive refuse an antibiotic for pneumonia, for example, may actually appear when they get pneumonia to want relief from it. And yet we still may follow their directive to not give an antibiotic. Thank you.
So I'll be brief. I know there are people here not only from New York, but from Delaware, New Jersey, and other places. The general rule most places is that your family has less authority to make healthcare decisions on your behalf than you have to make for yourself. And that's especially true if you haven't appointed them to be your healthcare agent in an advance directive. So you specifically chose them to make healthcare decisions on your behalf. So, and it's also true when you haven't specifically specified and given them the authority to make this decision on your behalf, you know, saying exactly what is it that you want and when is it that you want it. because in many jurisdictions, if you don't have permission, if the patient hasn't given you, the agent, permission to make this decision, they may lack the authority to make it on your behalf. And the exact scope of authority is going to vary from place to place. I just wanted to note there was a question in the Q&A about Nevada. Nevada is perhaps special because, like many states, there's an official state form. You don't usually have to use it, but it's one form that you can use that's developed by the legislature or the Attorney General's office. The official Nevada state form specifically offers the choice of refusing food and fluid. It's in a special thing called the dementia addendum to the advanced directive. So it's the one state where you have the legislature itself basically saying this making an advanced decision to stop eating and drinking is a choice that you can make. And perhaps we don't have quite that explicit level of clarity in any other state. Doesn't mean you can't do it in other states. We just don't have that level of clarity.
I just want to say that one of the challenges of this particular question is that probably the best palliative measure for the symptoms of stopping eating and drinking is swish and spit, right? So you put stuff in your mouth, you swish it around instead of to relieve the dryness, and then you spit it out. And as people lose capacity, that ain't going to happen. You're going to put stuff in their mouth, they're going to be drinking it, and they're going to say, give me some more, if they in their own way of saying it. So I think this is very, it's a challenging thing. And I think it's where we are often left with what might be called minimal comfort feeding only, or minimal comfort drinking only, where you say that we've got to palliate this, and we're going to palliate it with some oral intake, but we're going to keep it to an absolute minimum so we don't prolong it too long, because we know of their overarching desire in this circumstance.
So this may be our cue to move to official formal Q&A. Is everyone in agreement with that? Okay, wonderful. So we see here in the Q&A box, we have been replying to some. I do just want to start off the question and answer session with a question posed. What is the difference between euthanasia and medical aid in dying?
I'll just say the main difference is in every one of the 11 jurisdictions that allows medical aid in dying, and in every bill in New York and every other state that's seeking to become a medical aid in dying state, it requires that the patient take the medications themselves without assistance. In euthanasia, which is what's used in Canada and basically every other jurisdiction in the world, it's the clinician that administers the lethal drugs. I think that is the key difference between medical aid in dying and euthanasia.
Does any of the other panelists have a comment? No comment. Okay. And Thad, if you can just talk just briefly with medical aid in dying in the current states, or just some sort of overview, because I think we haven't touched on this in too much detail.
What are the states? So I'll tell you that there's actually something really exciting going on. So medical aid in dying is legal in, doing this off the top of my head, Hawaii, California, Oregon, Washington, Colorado, Vermont, Washington, D.C., New Jersey, and Maine. But of course, more than half of the other states, so 20 some other states, are seeking, right? They have bills almost every year to become a medical aid in dying state. There's a new lawsuit in California. So on this idea, this distinction between euthanasia and medical aid in dying, most people that use medical aid in dying have cancer, but the second most common diagnosis is ALS. And with that diagnosis and some other neurological diseases, they cannot self-administer. So that idea that the patient has to take the drugs themselves, there are people who literally cannot take the drugs themselves because they don't have enough muscle movement. So this lawsuit is basically suing the state of California, saying that that violates the Americans with Disabilities Act, because there's two terminally ill people. This one has cancer, this one has ALS, and you're not letting them have the opportunity of this law because of their physical disability, and that violates the ADA. So that lawsuit just started a couple of weeks ago.
Interesting.
I just want to reiterate that there are some important differences between medical aid in dying and euthanasia. And the main one is that medical aid in dying has the safeguard of the patient finally either having to take or not take the lethal medication by his or her own hand. Whereas in euthanasia, the clinician, another person, is delivering the lethal medication. And that could be determined by factors other than the immediate wishes of the patient. So that it is a little bit safer in that regard. It's much less flexible on the other hand, because there's a lot of requirements of being physically capable of swallowing it. You have to be able to swallow a lot of medication, whereas euthanasia is a lot more flexible and technically easier to do, which is a good thing and maybe a risky thing too.
Plus, there's also a waiting period that for some people who are getting close to death becomes really problematic, because there's a 15-day waiting period, 2 physicians that have to agree, and you have to write a written and verbal. It can be very challenging when you're actively dying.
And just to link this question back to VSED, if only 11 states have medical aid in dying, it's not available in the other states. Therefore, VSED becomes a comparatively more important option. Arguably, VSED is comparatively less important in the 11 states that have medical aid in dying. But to the point Judy just made, because of all the access hurdles, even in states like California, where medical aid in dying is an option, there's still a fair number of people who use VSED because they cannot access MAID, even though it's a legal option in their state, because of the eligibility requirements and all the safeguards that have to be satisfied.
Psychologically, it's also it's a completely different operation to decide each day whether you're going to continue with a choice that you've made. You get to decide whether it's harder than you thought, or you're not ready, or you want to wait you just found out someone's pregnant. Boy, drinking down that hemlock, that's a very dramatic choice. Quite different.
And that's why there are real cases where even when people are eligible for medical aid in dying, or even for euthanasia, they choose VSED.
Exactly
VSED,
right.
Some studies show that it's used as much in the Netherlands as euthanasia, actually. Yeah. And there are a number of cases, including one who spoke at the 2016 conference, that was noted, that Thad noted in his initial presentation on VSED. A very, very interesting presentation about a person who qualified for medical aid in dying in Oregon, but who decided that it was too cumbersome to pursue medical aid in dying, and VSED allowed a more natural death and with days of closure for the person. Now, it still may be much more difficult and require a very determined person, but that difference of difficulty drops when you have good palliative support, and the preparation, as you've noted, Judy and Tim, preparation for it is really good. So VSED is, I think, here to stay. It doesn't go away in the Netherlands when they have the most liberal euthanasia laws in the world, perhaps, and it hasn't gone away in Oregon.
So a quick case example of a patient of mine who happened to be an elderly Catholic nun who was very ready to die. And if she lived in the Netherlands, she would never have taken euthanasia in a million years. But stopping eating and drinking for her was something that made sense. She viewed it as a fast for God. And she had a beautiful self-controlled death at a time of her own choosing. So again, these are, we're trying to adapt these imperfect methods to the particular clinical situation and the values of the patient primarily, but also of the clinicians.
Excellent. I just want to highlight 3 themes in the Q&A box here. We have questions around finding supportive hospices, practical approaches to assist your loved one during this process, or as a healthcare professional dealing with that, and then life insurance policies, if we have any experience with that. So if we can just start with discussing area hospices. And Judy, I know that you've had some experience with this.
Patients that are enrolled in hospice who have a terminal diagnosis have no difficulty having hospice support for a choice to stop eating and drinking. It's stopping all life-prolonging measures is a very, very common decision that people with terminal illnesses make, and hospice has no trouble with supporting somebody who chooses to stop eating and drinking. So there are lots of I say there are lots of hospices. The size of the city and the number of hospices is pretty unbalanced, but there certainly are hospices, and I know that Tim has the upstate corner on hospices, and I think, isn't it true, Tim, even religious affiliated hospices will support a terminally ill patient's choice to VSED. Is that right?
I'd like to say yes, but I wouldn't stake my entire life or reputation on that, the answer to that, because I think they're very different. Now, again, I think most places have more than one hospice. I think it would be unusual to find a hospice that wouldn't support it. And again, it would also depend a little on how close to death the patient was without VSED. So again, patients who are in the very end stages, I think it's very hard to tell whether it's really VSED or not. Whereas if somebody was pretty good shape, in hospice terms, and was making this big decision to do this, I think hospices would be somewhat anxious about that. Some hospices would.
Sorry, and the other thing that really matters is the language that you use. If you ask hospice to help you die because you've decided you want to die now and you want their help, they're likely going to tell you that that's not what they do. They certainly provide comfort, but they don't hasten death intentionally. That's not what they do. That's not what they're about. So you have to know the language to use. You have to do a little tap dancing sometime, and I'm very good at choreographing tap dancing. And you do need that. You do need to check in with somebody who's been, I hate to keep using these things, but to the rodeo before. You need to know where the pitfalls are and what to do. The more serious problem, though, is people that are really suffering from incurable and progressive diseases, and they're miserable, but they don't have a terminal diagnosis. And then it becomes very, very challenging to find a physician who will act as a palliative partner in the journey and write the prescriptions. And it's not rocket science. We're not talking about really fancy drugs here. We're just talking about small amounts of opiates and small amounts of anti-anxiety meds that can be given orally. However, it can be a real challenge. So if people are looking for specific clinical advice and you want to, give me a call. We'll walk through it, because there are ways to approach this, and there are definitely ways to not approach it. I like to think that if plan A doesn't work, there's plan B and plan C, and that's the way you have to approach it, because each case is unique.
And Judy, I think that's a great lead into how you are managing symptoms. There's a lot of questions and kind of expression of concerns in that VSED is very hard to maintain until the end. So if you and the others could kind of speak to, hands-on experience of the use of those medications and comfort measures.
Well, I mean, the thing that's most important is that somebody fully understand exactly what's involved and what to expect and how this process unfolds over time. You can't go into this uninformed. You really have to really understand what it's going to be like. You have to understand those things that I said need to be in place. You need to have support. I get calls from people all the time that say, I don't want to tell anybody about this. I just want to do this by myself. And it's my secret, it's my business. And I say, well, good luck with that. It's very, very hard to do on your own. You can't, in my experience. So in terms of specific symptoms, I mean, Tim can jump in here too, but it's not that the dehydration itself is painful. People think that, oh my God, this is so painful, it's so horrible. Having a dry mouth is very, very, very difficult. But as Tim said, there's so many basic, easy nursing care, oral care, rinsing and spitting, mouthwash, those swabby things that hospice gives you, a washcloth that you wring out with water, put in the freezer, you can suck on it, brush your teeth, mouthwash. There's lots of different things that you can try, a fine mist that you spray on the back of the throat. The whole goal is comfort. It shouldn't be torture. So however you can navigate that with emotional support from people who understand this decision and why you've made it. And you need to be sure that this is what you want to do. It's very hard to not be ambivalent about intentionally hastening your own death. You know, it kind of goes against the hard wiring that we all have. However, for some people, the alternative, the suffering that they're having to endure, and as I say, they get to decide what that is just unbearable. And it's clearly not for people who are having a bad hair day. And nobody else can do this for them. They have to do it themselves with support from others. So beyond that, it's an individual case and people should just give me a call. We'll talk about it.
Thank
It's
you.
not my role, perhaps, to say this because I'm not a clinician. I haven't had anything like the experience that Tim and Judy have had. But I have had some experience with several cases over the last 10 years in my life, direct experience with people who've done VSED. And as is also noted in our book, hunger is not the problem, thirst is. And the image that people have of VSED is an image of self-starvation. Self-starvation. And as soon as that term starvation gets put on it, then people think this is going to be very, very difficult. I will want to eat. But there's lots of documentation and lots of experience that your desire for food tends to shut down at about 48 to 72 hours. Those who've been on health fasts for protest purposes or whatever have had the experience of noting how unhungry they are after 72 hours. Doesn't mean that they're not hungry, but it's not painful hunger. Thirst, on the other hand, is the big problem, and that's what Judy and Tim have said. It needs to be addressed, needs to be well understood. It is difficult. On the other hand, I know two specific people in Ohio who did it without any palliative assistance at all. And they were very determined. They were very unusual personalities. So it's not for everyone, but even the tough way without hospice support or even without much palliative care is a possibility for some people. That would be very, very rare and certainly is not advisable. But above all, we should just get rid of the image that hunger is the problem, that starvation is something difficult here.
Yeah, I think the approach that should be agreed upon is that you're going to, once it's started, if you are sure you want to do it, if it gets uncomfortable, you're going to err on the side of comfort. By the way, the patient's dying. And that's what we do. It's that standard hospice care. If somebody's uncomfortable, you up the whatever treatment is required until they're not uncomfortable or until they're sleepy. And then you keep it there because it's the point of having them be more uncomfortable again. It doesn't make any sense.
Yep.
Okay, I want to move on to the question around the MOLST form. Is the MOLST form a mechanism to document VSED?
Let me just say one thing about that. There's a section that talks about the level of comfort care. I mean, the level of care you want, whether you want aggressive interventions, whether you want, middle interventions, or whether you want comfort measures. And in that section in the New York State MOLST form, I mean, it was in the last one, maybe you're more current than I am, Tim. There's the sentence that says, I will be offered food and fluid as I, enjoy eating and drinking. So if you're planning to VSED, you might want to put a line through that and say, see my attached advanced directive to stop eating and drinking with specific instructions about how you want that handled. But aside from that, I think it's great.
I'm going to reinforce exactly what Judy said. The MOLST form is great, except on that particular issue, because the standard of care, if you're on hospice, is as much or as little as you want to eat to drink, because, as much as needed for comfort. This is a different approach. So you're changing that part. It should be very explicitly changed. It should be clearly documented so that the people who are doing it are reminded that's what they're supposed to do, and they're reminded that's what you wanted.
And as we all know, if there's conflict between the papers, between the written thing and the verbal thing and the MOLST thing, clinicians just throw up their hands and say, you guys sort this out and you let me know when you all come together, because I'm not, and the default is to keep treating until you guys get it sorted out. So you want to be sure that all of your papers are lined up and they all say the same thing.
Excellent. And so for the clinicians who are caring for these patients who have these directives that may struggle with following through, that there is just on the ethical side that they're making the decision that this person's suffering and they want to help that person. If you possibly could just talk about any stories that you have of that, any sort of counseling or trainings that have been done over the years.
Well, I mean, talking through what you're trying to do and what your obligations are in advance with somebody who's experienced. And if you're going to some clinicians, like everybody else, we have our edges, right? That we say, well, I can do this, but that doesn't feel very good. And for some, VSED might be on the edge or maybe over the edge, right? Because it is intentionally hastening death. And in certain religious traditions, that's over the line, right? And now what really counts is the patient's religious tradition, the patient's morals, that's what counts the most. But the clinician who is assisting really has to be able to wake up in the morning, right? And feel that they haven't violated fundamental values. And if they feel like they can't do that, then they need to think about getting a second opinion, getting somebody else to take over, because you need to have somebody who's on board. There's enough challenges with this that you have to have somebody who's really got the goal clarified and is going to do their best to achieve that, help you achieve that goal. And if you're really mixed up on that and you can't solve that, then I think getting somebody else involved is a good idea.
And I totally agree with Tim, and I would add to that, you really would like to have a clinician who's actually cared for a VSED patient in the past, who understands what this process is like, as opposed to somebody who has heard horror stories about, swollen tongues and gosh knows what all about the terrible things that can happen if you stop eating or drinking. So I always say to patients and families, if that person coming through the door who stands for hospice and they say, I'm here to be your partner in this whole process, if there are religious challenges that you pick up on, if there are clinical practice issues that you have struggles with, you have every right to call the supervisor of that organization and say, would it be possible to send another nurse clinician, because I think that we're having kind of a difference of opinion or a difficulty communicating. And she's perfectly lovely. He's wonderful, but I would feel better having somebody else.
I would only add one thing to what Judy said, which is conscience-based objections can be asserted not only at the individual clinician level, but at the entity level. Yes. So Catholic affiliated entities, for example, the whole entity's out, right? They're not going to do medical and dying, and they're not going to do VSED. So when planning, for example, a hospice or a long-term care facility where somebody might go with dementia, if VSED is part of your plan, you might want to avoid certain religiously affiliated institutions, not just to help maximize the chance that your wishes get honored.
True that.
Excellent. And in the New York, New Jersey region, there has definitely in the last several years been an uptick in having palliative care medicine teams on site. And so very hospital based, and they're sort of the team responsible in educating the other clinicians and providers. Is there any other additional training and recommendations for staff that are attending this now, not only in hospital settings, but other facility settings? What do you recommend to help guide them to get the message out there? You know, other than, you know, we do have the book and buy the book and spread the word, but what other resources would you suggest?
Well, in our institution, our palliative care team has put together a curriculum for the generalists, you know, the hospitalists, the generalists, and for the oncologists, and now even the cardiologists have taken our class. And this is not rocket science, you know. It's probably 3 or 4 sessions of learning about basic pain management and basic shortness of breath management, and then looking at options that might be available at the very end. So again, I think if you have an institution that's ready to learn about those things, it's a great investment for a palliative care team to train, you know, the other clinicians who care for really sick people to do the basics of this. And then if they get stuck, they can get us involved and we'll muddle through it with them. But the basics of this is not rocket science. It's a matter of having some basic knowledge and the will to try to make it happen, and see it as your obligation. The patient's dying, keeping it as comfortable as possible is the best thing to do morally, ethically, and legally.
Excellent. And I'll ask Lillian to just post our email address in the chat for any organization or facility that would like to speak to us in more of an intimate conversation than on this webinar. We are happy to discuss that with you. I'd like also to ask the panelists just to clarify the advanced directives specific to states, whether New York, New Jersey. There was a question regarding the crossover of these advanced directives.
So I'm not sure. Well, end of life choices, of course, New York has its own special directive. A bunch of people have been developing similar instruments, so Final Exit Network and Dartmouth University Medical School and Compassionate Choices. And so this is, a lot of people think they have the right magic language or the right design. So these are being disseminated widely across the whole world, because Exit, which is a Swiss organization, this is being used in Europe as well. Yeah, and there's no reason why any of these couldn't be used in any state, right? So you could, the end of life choice, for example, your form, I think is intended to be added, right? So you would have your regular advancce directive from Ohio, for example, and you could staple the end of life choices document onto the back of that. And I think that would be true for any state, except there are a number of states where you couldn't do that, because they specifically say advanced directives are for healthcare decisions and food and fluid by mouth is not healthcare. So the law literally says that. So it wouldn't be available, for example, in Wisconsin. But in most states, I think you could take your form and anybody could take your form and use it in New Jersey, use it in Delaware.
That's specific to the question. If the question was about advanced directives to stop eating and drinking, I'm not sure, Christina, whether that was the question. If you're talking about just healthcare proxies and living wills, I think, you know, Thad will of course correct me here, but they're interchangeable. You know, I mean, most states will honor other states' advanced directives, right?
It was the VSED advanced directive if it can cross state lines.
Oh, yeah.
Well, it's not a VSED advanced directive. It's because if you're you have to be capacitated in order to make a voluntary choice to stop eating and drinking. If we're talking about an advanced directive to limit future hand feeding, that's an advanced directive to stop eating and drinking. I'm sorry to be so picky, but it's important because the person has lost capacity. So sorry, what were you going to say, Thad?
I was only going to say that almost every state has a reciprocity clause. So New York will honor a Vermont directive, and Vermont will honor a New York directive, and things like that. Some people started to get super clever and think, "Ooh, I'll take that in Nevada," because I mentioned a minute ago that Nevada has a very clear right to have an advanced directive for stopping eating and drinking. So people thought, "Oh, I'm a New Yorker, but I'll complete a Nevada advanced directive for stopping eating and drinking, and then New York will have to honor it because of the reciprocity clause." Technically, that probably works, but it's a little cute, because it really comes down to the question of, will your attending at the healthcare facility where you are honor that? It doesn't. Sometimes the law doesn't. What the law actually requires is different from what specific clinicians are willing to do.
I want to say that the majority of people who are seriously ill and dying don't have any advanced directive. So having any advanced directive that really clearly states what you really want and what you don't want is fantastic. And I don't care if it's from East Oshkosh or whatever. It's a huge help to have a statement, and having it be as detailed and specific as you want is great. But that's a much bigger problem than not having the specifics of these things.
Yeah, and well, since you made that great point, Tim, it's also important not just to complete an advanced directive, but then to make sure that it gets found. So if you're appointing somebody, give it to your agent, give it to your alternate agent, scan it and load it to your electronic health record. And most states now have a registry, upload it to your state registry. So because many people, Tim's right, most people don't have an advanced directive. Unfortunately, most of the people that do have an advanced directive, they have it, but nobody else has it. And therefore it becomes useless because it's in a drawer back at home somewhere and they're unconscious in a bed.
And adding to that, the problem is with a healthcare agent that's been appointed and may not know that they've been appointed, and they have never had a conversation with this person about what their bloody wishes are. And that might have been 20 years ago, before they got emphysema and they were now needing dialysis. So if you appoint somebody to be your healthcare agent, you have to keep telling them as issues come up in your life, your clinical life, that make you rethink the plan that you made 20 years ago. You must be sure that your agent is current and understands and will advocate for your wishes. In addition to being able to find the damn document, I agree.
And just to make it even more complicated, those change in wishes could go in either direction, right?
Yes, true. Yes, true.
It might say that you want more aggressive palliation and less treatment, or it might say that you want, I thought I didn't want those things, but I found out life is pretty freaking precious, and I'll take a lot more than I thought I was going to take.
You never know. You never know how you're going to feel. Absolutely, I agree.
Excellent. Well, I want to just note this is the end of our excellent panel of editors. I want to thank you all. I want to thank our attendees this evening for excellent Q&A. We will be rounding up any unanswered questions and submitting them, sharing them. Just give us a couple of days for some feedback, and we will email that to all. I want to make a mention to our sponsor, Caring People, Inc. We will have the contact info in our chat. They are a licensed home care agency providing at-home services for the past 25 years. And that is a wrap. Thank you so much.